I wanted to talk about the title and then go on with the first set of slides. So the title, I changed it slightly to a Paleolithic perspective on stone disease in Sri Lanka. So Paleolithic perspective means a very ancient perspective at the time of the caveman, and I will explain what that means further in the next few slides. So I just wanted to open with a very big thank you and acknowledgement. It's a real honor for me to come here and present to all of you. And this is part of a trip that has been planned for over a year. So about a year ago, we got a grant award to study kidney stone disease in Sri Lanka. This was an inspiration by Dr. Nanyakara as well as Dr. Suchi Anand. And so we've been meeting over Zoom meetings for the past year, and I've never actually seen everybody in person until this week. And I really want to acknowledge and thank just the warmness and the just the gracious hosts that we've had here, including Dr. Nanyakara, Dr. Chandrath, Dr. Herath, as well as Shaminda Jayasena. Here are some pictures of us on rounds with Dr. Nanyakara at Kenny Hospital last week. We also went to the University of Peradeniya and visited Dr. Chandrath in his laboratory. And then here on the bottom is Jaminda doing a food frequency questionnaire with a patient in Wogamoa. I also wanted to thank the CKDU team for making us dinner, making us feel very welcome in Wogamoa. And I also wanted to thank Dr. Suchi Anand, who's sitting in the front, and welcoming her and welcoming me to her projects on CKDU in Sri Lanka over the years. So the outline of the talk, I'm going to break it up into 4 parts. I'm going to start by reviewing how do kidney stones form and grow. And then I would like to go over some theories of why kidney stones occur in the first place. It turns out that kidney stone disease across the world has increased over the past few decades. And so I'll try to come up with a hypothesis to see why that might be. And then I want to be more specific about why do kidney stones form in people in Sri Lanka. And then finally, I'll review some of the preliminary sort of goals of our stone project that is taking place in Sri Lanka right now. So just as a review, because I know that the audience has a lot of different backgrounds, kidney stone disease is fairly common, and they typically come to attention when patients form a stone that usually is at the area of the renal pelvis. And these stones form in the renal pelvis typically, and they don't cause any problems until they grow to get really big, and then they break off, and they get stuck. And they get stuck either at the renal pelvis, at the junction with the ureter, they can get stuck in the mid-ureter, or they get stuck at the junction between the ureter and the bladder. And with the obstruction, the ureter will contract to try to get the urine across the obstruction, and that contraction causes this sensation of pain and pressure, and that's what brings patients to the clinicians for medical attention. Now, I realize in the past week, I've met a lot of stone patients from Sri Lanka, and their stones are really, really big. And I think that probably much of them seem to be stuck out here, and I think the urologist can kind of tell more about that as well. But typically, it's the obstructing stone that will cause problems. And this obstruction can cause renal failure. It can also cause urine infection. And again, it causes a lot of pain. So kidney stone disease is very common and very costly in the United States. We estimate that about 1 in 11 patients in the United States will experience a kidney stone in their lifetime. It's the 8th most common visit to the emergency department in the United States. Again, it costs millions of dollars to evaluate these patients because they come into the emergency department frequently for the pain, and they require stone surgery, which is also costly. And as I mentioned before, over the past few decades, the prevalence, how common the stone is increasing, and we don't quite know why. Another problem with kidney stone disease is that about half of patients will experience another stone in about 10 years after the first stone. So stone disease is painful, it recurs, and it's expensive. Okay, so how do stones form and grow? And I think to understand this, I think it is useful to compare the pathogenesis of stone formation with the process of making rock candy. So this is rock sugar candy. And I've been told that children in Sri Lanka also, like in the United States, will eat rock candy. And the reason I compare stones with rock candy is that both of them depend on the generation of a solution that is supersaturated. So with respect to rock candy, it's supersaturated with sugar. With respect to kidney stones, the urine is supersaturated with minerals that contribute to stone formation. So to make rock candy, you have to add water to a jar, and you add enough sugar so that all of the sugar dissolves into the water, and there's a little bit left over in the bottom of the jar. And then at this point, this solution is what we call saturated with sugar. And then you heat the jar, and when you heat the jar, the heat kind of dissolves the extra bit of sugar at the bottom. The heat raises the solubility of the sugar and takes up the sugar. And at this point, when you cool it, the sugar actually remains in solution. And at this point, the solution is what we call supersaturated for sugar. And it will stay that way until you shake the jar or you stick a wick into the supersaturated solution. And over time, sugar crystals will form on the surface of the wick, leading to the formation of rock candy. And so this is how we approach stone prevention in the clinic. So the kidney makes urine and excretes it every day. And for some patients who have kidney stones, their urine is supersaturated for minerals that can lead to stone growth. And so one of the major things that we do in our stone clinic is that patients with kidney stones, we get 24-hour urine collections to get an idea of how supersaturated their urine is. And we can then take components of the minerals and try to lower the risk of the offending minerals that lead to the stone. So this is data from my clinic at the Paleolithic Veterans Hospital. And here in the course of a year, we see that of the 60% of patients who did give us a stone to analyze, about 3/4 of them contain calcium oxalate. And this is the most common stone type. About 11 to 12% have calcium phosphate stones or uric acid stones. So again, calcium oxalate is the most common stone type that we have in the United States. And here are some calcium oxalate crystals that you can see here in the urine. And the urinary risk factors for calcium oxalate stones are any one or more of the following. So low urine volume, hypercalciuria, which means high calcium in the urine, hyperoxaluria, which is high oxalate in the urine, or hypocitraturia, which is low citrate in the urine. Citrate is an organic compound that has 2 negative charges that can bind to calcium and keep it more soluble in the urine and away from calcium, away from oxalate or phosphate. So citrate is the main stone inhibitor for calcium stones. More rarely, patients may also have high uric acid in the urine called hyperuricasuria. The mechanism of how uric acid in the urine leads to calcium stones is still unclear. So just for today, I'm going to focus on hypercalciuria, hyperoxaluria, and hypocitraturia. So again, these are risk factors of urine that lead to crystal growth in the urine to form stones. So this is a report of 24-hour urine collection. So what we ask the patients to do is collect their urine for 24 hours, and then we send it to a laboratory. And you can see here, there are many factors that are measured here. So one of them is the urine volume. I can't actually see that well, but I think it's calcium, oxalate, citrate, uric acid, pH, and then on the bottom are sodium, potassium, and then let's see, magnesium, phosphate, ammonium. And then here are markers of protein in the diet, including sulfate and urinary and nitrogen. So we get serial 24-hour urines when we try to change the diet. Actually, when we get a baseline diet and then we try to change the diet, and then sometimes we'll add medications to try to change the profile of the urine so that the stone risk is less over time. So this is a patient. So here are some urine studies starting from earlier to the most recent stone. So these are like 8 24-hour urines from the same patient. So this patient has recurrent calcium oxalate stones. He's German and he tends to eat a lot of, he tells me, sausages, cold cut meats, salted breads, and fish. And so you can see this is the calcium in the urine, the 24-hour urine calcium. In the next slide, I'll tell you that anything over 200 milligrams a day increases your risk for calcium stones. So you can see that his urine calcium is very high. It's over 200, sometimes up to 727 milligrams a day. So this person has hypercalciuria. When the calcium is high in the urine, we also look at the amount of sodium that's in the urine, as well as markers of dietary protein. And so the assumption is when you do a 24-hour urine, it's under imbalance conditions. So what you pee out is a reflection of what you put into the body the previous day. So under steady state balance, the person's sodium of 449 milliequivalents meant that he ate around 400 to 49 milliequivalents of sodium in the diet on the day of the collection. These are protein markers like urine sulfate and urinary nitrogen. When these are high, they can also make the calcium high. So in this particular patient, hypercalciuria is associated with high dietary sodium intake and excretion, as well as high protein intake and excretion of markers that reflect acidic proteins. Okay, so just to review, hypercalciuria is defined as a urine calcium excretion of greater than 200 milligrams a day. This is the most common abnormality for recurrent calcium stone formers. The causes are generally thought to be idiopathic, and this diagram here can be helpful in terms of thinking about the causes. So here it's hard to see, but here's the gut and here's the ECF space. And so calcium comes into the body through the gut, gets absorbed, and it can exchange with calcium with bone, and then it's excreted into the urine by the kidney. So causes of high calcium in the urine is thought to be one or more of the following. The gut absorbs too much calcium from the diet. Bones resorb too much calcium into the body and then into the urine, or the kidneys leak calcium into the urine. So any one of these factors in combination or isolation can cause hypercalciuria. In terms of treatment or prevention, we typically, again, recommend that the patient decrease the salt intake, because as you decrease salt in the diet, there is less sodium that gets excreted, and there's also less calcium that gets excreted at the same time. We also ask the patients to moderate the protein in the diet. Proteins actually contain acidogenic amino acids, and an acid diet can also prevent the kidneys from absorbing the calcium and leaching calcium into the urine. There are also medications like hydrochlorothiazide and chlorthalidone that can be used to be more effective in terms of reducing urine calcium excretion. Okay, I'm going to go on to another risk factor. This one is a patient who has also recurrent calcium oxalate stones. And he ended up presenting to me as a vegetarian first, and he was eating a lot of green leafy vegetables that contain spinach, and he liked to eat a lot of nuts. So before I show you the oxalate, I just wanted you to see that this patient actually, you can see that over time his calcium in the urine, so this is earlier versus the most recent 24-hour urines, you can see that the calcium goes up to about 548. And that's because over time he became vegetarian and then decided to eat more protein. He stopped becoming a vegetarian. He started to eat a lot of meat. And you can see here that markers of protein intake increase. The sulfate goes up, the urinary nitrogen goes up, and also the sodium goes up. And you can see that his calciums initially were normal, but then they increased as the salt and the protein increase. But he also has a problem with oxalate. So again, he was eating a lot of spinach and nuts that contain a high concentration of oxalate in the diet. And so after several meetings with our dietitian, we asked him to cut out nuts from his diet and switch his greens to more spinach, away from spinach. And he was able to lower his oxalate excretion in the urine to a normal range of around 30 milligrams a day. So that was an example of hyperoxaluria. So this is high urine oxalate excretion, defined as anything greater than 40 milligrams a day. So again, the causes are that there's just a lot of dietary intake of oxalate-rich foods. So this is typically dark leafy greens like spinach, chocolate, nuts, and tea can also do that as well. In the United States, a lot of patients like to eat vitamin C supplements. Vitamin C can be metabolized by the liver to generate oxalate. And then there are enteric causes of hyperoxaluria, typically classically seen with inflammatory bowel disease like Crohn's disease. In the United States, there are patients that we have that will also undergo gastric intestinal bypass surgery for weight loss. Some of those patients can also have fat malabsorption, leading to calcium binding to the fat, and then the free oxalate is actually absorbed by the gut and then excreted into the urine. So treatment for hyperoxaluria is to basically restrict dietary oxalate, try to switch them from high oxalate foods to low oxalate foods, and then sometimes we will give calcium with meals to try to bind up the oxalate that's in the food so that the gut does not absorb as much oxalate into the body. So the final risk factor I just wanted to highlight with 24-hour urine collection is a patient that I had that had mixed uric acid and calcium oxalate stones. And so here you can see that the patient, this is again, most recent is up here. The first visit I had was down here. You can see that the citrate level is actually fairly low. You typically want the citrate in the urine to be above 400 milligrams a day. Now remember, citrate is an inhibitor of stones. So if you have low levels of citrate, then that means you don't have the inhibitor that can actually prevent the stone. So you try to replete the citrate in the urine by giving them alkali, either in the form of bicarbonate or potassium citrate. You can see that over time we gave this patient more sodium bicarbonate, and the citrate went up into the normal range. Okay, and this is protective because now the patient has more citrate in the urine to prevent calcium oxalate stones from forming. So urine hypocitraturia is defined as a urine citrate of less than 400 milligrams a day in the urine. Again, this is citrate here in red, so it's a 6-carbon compound. It's actually a byproduct of the TCA cycle for oxidation of carbohydrates. Citrate can bind to calcium through these negative charges and keep it away from oxalate and phosphate. So the treatment is to try to raise excretion of citrate into the urine. We can do this by, again, giving alkali in the form of potassium citrate or sodium bicarbonate. Okay, so I'm going to move on to the second part of the talk, which is to kind of review my thoughts on why kidney stones might form more in the modern era. Kidney stone disease seems to be increasing worldwide, and so we don't quite know why that might be. So one way to kind of think about why this might occur, why kidney stones are more common now, is to consider how the human species have evolved over several millions of years to maintain homeostasis. So this is a evolutionary time scale, and so this is 2 million years represented in this line. Our human ancestors 2 million years ago ate a diet that was that consisted of uncultivated plants and vegetables and a little bit of meat from wild animals. So this is what is known as the Paleolithic diet. So this is kind of like the caveman diet long time ago millions of years ago, this is what all of our ancestors ate. So this Paleolithic diet has a high dietary potassium, has very low sodium, and the ratio of alkali to acid precursors is also high because fruits and vegetables contain organic anions that can be oxidized to yield bicarbonate and base for the body. And because there's not a lot of meat, which is more acidogenic, this means that the net load to the body was more alkaline. So another way to say that is that our ancestors had a net negative acid load. Okay, so then about 10,000 years ago, our diet of our ancestors changed significantly. And it changed significantly because of three technological innovations. So about 10,000 years ago, there was the invention of farming, of agriculture. So now our ancestors could grow cereal grains like wheat and rice. And this allowed them to have a reliable source of food to eat so that people wouldn't starve. Now, one of the problems with cereal grains, though, is that they contain more acidogenic amino acids. So compared to uncultivated fruits and vegetables, cereal grains like rice and wheat contain more acid than what our ancestors had eaten. A second innovation was the invention of animal husbandry. So now we have livestock that we can have cows, we have sheep, we have chicken, we have pigs. And this was another reliable source, this time of protein. So we can eat these domesticated animals for food, for meat. And so this is how we became more, we became taller, we became stronger, we might live longer because of the protein. The problem with protein is that protein contains a lot of acidogenic amino acids as well. And then finally, in the past 100 to 150 years, there's industrial scale food production. And this includes salt. So now we can make very high calorie dense foods that might be nutrition poor, and it can contain a lot of salt. The salt acts as a preservative. It also makes the food taste better. So now we have something where our ancestors ate a food like this to something that looks like this. So this was actually a meal that our CKDU team made for us at Wogamowa. It was delicious and it was really good. It has some fried rice. It's got some shrimp curry, potato curry, also some tea, and also a little bit of beer. But all of these things are very different from what our ancestors ate. It tastes really good. It has high calories. The modern diet contains less potassium because there's less fruits and vegetables, more sodium, and also the ratio of alkali to acid precursors is low, meaning that there's more acid in our diet. So this comes in the form of acidogenic amino acids from protein and also from the acidogenic amino acids from cereal grains like rice. So all of these things can increase your risk of having stones. So the high sodium in the diet, as well as the acid load in the diet, can raise urinary calcium excretion. And this is because acid loading and dietary sodium will inhibit the ability of the kidneys to reabsorb calcium in the proximal tubule of the nephron. And this leads to an increase in calcium in the urine. The high acid load can also reduce urinary citrate excretion. This is another way for the kidney tubule to reabsorb citrate. It can block that. It stimulates citrate reabsorption in the proximal tubule so that there's less citrate in the urine. And then finally, the acid load can actually reduce the urinary pH, leading to risk of uric acid stones. So here's a table of the daily estimated nutrient consumption of the Paleolithic diet compared to the modern diet. These are estimated by a variety of papers. And again, you can see in the Paleolithic diet, there's more potassium, less sodium, such that the ratio of potassium to sodium in the diet is 10-1. With the modern diet, the potassium is low, the sodium is high, so that the ratio is potassium to sodium is 1-3. It flips. And again, the net acid load becomes negative to a positive acid load. So the modern diet is more acidic. And again, just to kind of, well, actually, I'm going to go up to this side here. So how does this relate to stone disease? So I think there's a mismatch of the time scale between human evolution and the change in diet. So you can consider that we evolved over several millions of years, but this change in the diet that occurred 10,000 years ago was very drastic and represents only 0.5% of evolutionary time. So in other words, our bodies and our kidneys are used to a caveman Paleolithic diet, and it hasn't had enough time to adapt to this modern diet that, again, has more salt, it has more acid precursors, and so this increases risk for stone disease. This occurs by increasing urine calcium to give calcium stones. It can lower urine citrate to give calcium stones, and it can also lead to generation of acidic urine to give uric acid stones. Okay, so if there's any questions on this, I'm happy to answer more about the mechanisms of how this happened. Just out of the interest of time, I'm going to move on to the third point, which is why do kidney stones form in the people in Sri Lanka? Because this is why we are here. We're trying to figure out, is there more stone disease in certain parts of Sri Lanka? And the answer is, I don't know. And I think if any of you in the audience know of papers or your own anecdotal sort of experience, I tried to look for stone prevalence data from hospitals in Sri Lanka, and I couldn't find a lot of the period prevalence of stone disease in Sri Lanka. What I did find was some reports, like this one in 2002, from a group in the National Hospital in Colombo. They described 3,000 patients who had shockwave lithotripsy in 2002. This other paper here in 2018 was a series of 116 patients that were seen at Rikilagaskada District Hospital between 2010 and 2011. But apart from this, there's not a lot of data of how frequently people have kidney stones in different parts of Sri Lanka. What about stone composition? So this is a paper from Dr. Chandrajith's group in 2019, where he analyzed 100 stones that were collected from patients getting stone extraction from Colombo South National Hospital. And from this data, he found, their group found, that 60% of the stones analyzed was calcium oxalate, about 30% was mixed with calcium oxalate and phosphate, and about 5% of uric acid stones were uric acid stones. So this is a little bit lower in proportion than what we see in the United States, but this is just one sample from one hospital. So why might patients in Sri Lanka form kidney stones? And I think it's helpful to kind of think about certain risk factors that can combine to form stones. So there is climate, there is the diet, as we've talked about, there's also water quality, and then also the genetic background that might predispose patients to forming kidney stones. So let's look at each of these. Actually, I won't go over the genes part, but let's look at the climate. So this was a study, again, by Dr. Chandrajith's group, and he looked at climate and water quality in the Central Highlands. And this is relevant because we think, we're not sure, that there might be more stone disease in the wet zone of Sri Lanka compared with the dry zone. So for this particular study, Dr. Chandrajith's group looked at patients with stone disease in the wet zone, and he identified 54 patients who had kidney stone disease in this area compared with 29 who did not. And then he looked at the water samples for each of these and analyzed them. So in terms of climate in the area, the average rainfall in the wet zone is about 2,500 millimeters per year. Primarily, the occupation of these individuals is that they do vegetable and rice paddy farming, also some tea. The source of water is primarily from natural spring water, and this spring water mixes with high-grade metamorphic rock. In the 54 patients that he analyzed that had kidney stones, about 78% were male, and almost all of them drank from the natural spring water. Then he looked at the water quality of the patients who had the kidney stones versus those who did not. So in terms of what's relevant to stone disease, there's a parameter called total hardness. So this is the amount of calcium and magnesium in the water. You can see in the people who had kidney stone disease, their water was 70 milligrams per liter, compared with the water of those who did not have stone disease, which was 42. The calcium concentration was 18.1 in the water of the patients with stones versus 9.5. The pH was also higher in the water of patients who had stone disease compared to those who did not. So Dr. Chandrajith's group concluded that the spring water from patients who had stones contained more calcium and bicarbonate, and this might reflect dissolution of carbonate minerals in the metamorphic rock from where the spring water came from, which consists of marble. So I just wanted to caution, though, that 18 mg per liter is actually not that high, even though it is harder than the water that was from people who had water who didn't have stones. And the reason I say that, you could imagine that, let's say a patient is drinking water that had 18 milligrams per liter. A typical person might drink 2 liters of water a day. That's only 36 milligrams of calcium. That's not a lot. So in terms of what we recommend our patients in the United States who have kidney stones, we recommend that they eat 1,000 to 1,200 milligrams of calcium in the diet. So compared to a number like 1,200, the 36 it's not nothing, but it's also not near the 1,200 that we ask patients to eat every day. So I'm not sure if this hardness can completely explain why these patients might be getting kidney stones. There might be something else. That something else might be the diet. So this is a nice national survey of food consumption in patients in Sri Lanka. This is a national survey, so it's not specific to a particular region. This was part of the Sri Lanka Diabetes and Cardiovascular Study, the survey done in 2005 and 2006, and again in 2011. It comes from 600 people in clusters from 9 different provinces across the country of Sri Lanka. And these investigators conducted a 24-hour dietary recall. And so this chart I just wanted to show is the average daily food intake of the participants in this study. So here, the left column is the average intake of Sri Lankan adults in the study, shown here. This is the national recommendations of each of the food groups in the study, and this is also the U.S. recommendations in terms of portions per day. And so you can see that in patients in this study, they ate more starch compared to what is recommended in the national recommendations. They also ate fewer fruits and vegetables compared to what is recommended. And they ate more meat and pulses compared to what is recommended. There's also a very low amount of dairy intake in the participants that they surveyed. So I'm actually curious if this makes sense or not. I don't know because I don't live here, but it seems like Sri Lankan adults in this study actually, they eat more starch in the form of rice, more protein, more sodium, and less fruits and vegetables and less dairy. That's one of the conclusions of this particular survey. And then I skipped this slide here. This is a different survey of salt intake in Sri Lanka. We care about salt because, again, more sodium in the diet means more sodium in the urine and more calcium in the urine. And this leads to stone risk increases. So here, there are 2 surveys in 2012 and 2022 estimating that the amount of dietary sodium in the Sri Lankan diet is about 178 milliequivalents per day and 156 milliequivalents a day, which is actually not that high compared to what Americans eat, but it's still above the 100 milliequivalents per day of what we recommend for stone prevention. One thing to note is also in this 2022 paper, they noted that participants also like to add salt to rice as well as salt after they cooked as well. So there are some patients who ate a lot of sodium, but not all of them did. So just to summarize here, I think that the dietary pattern of at least the national sample is consistent with a diet that can promote stone risk. Whether or not that's happening in the dry zone or the wet zone, we don't know because we haven't done those particular studies yet. But again, just to kind of review, rice is a cereal grain. It has more acid precursors that can increase your calcium excretion. Protein in the diet can also increase calcium excretion. Sodium also can increase calcium excretion. Less fruits and vegetables will lower the amount of alkali to the body, lowering urine citrate. Less dairy actually is another way of saying less calcium in the diet that can then lead to the gut to absorb more oxalate. This can also lead to high urine oxalate excretion. All of these factors can increase your stone risk. Okay, so I'm going to conclude with the last part of the talk, and that is to review the aims of our stone project in Sri Lanka. So last year, we submitted a study in collaboration with many of you in this room here to study patient and environmental factors that drive kidney stone disease in the wet zones of Sri Lanka. And this was based on the hunch by Dr. Nadia as well as Dr. Chandra that there might be more stones in the wet zone. We don't know, but it might be worthwhile looking at these two different regions. And so our Sri Lankan team is led in National Teaching Hospital at Kandy, Dr. Nadia Kara, as well as Dr. Harith at University of Peradeniya, Dr. Chandradrith and Shaminda Jayasena. And then we also have collaboration with district hospitals in Kilakaskada, as well as Mandarawara, and we're working on some more hospitals in Wogamua. Our Stanford team, so just for people who don't know where Stanford is, it's on the west coast of the United States. It also has palm trees, but I realize that the palm trees here are fake. The ones that you have in Sri Lanka are real. So our team consists of nephrologists and civil engineers. So Dr. Kalyani Ganesan, she couldn't come with us on this trip, but she's been working in the background, and Dr. Anand and myself. And then the civil engineering team is Dr. Khalid Osman, as well as Adi Mohanavelu, who is here with us in the front row. And so the idea is that we have three aims. Our first aim of this project is to determine the regional variation of kidney stone disease in Sri Lanka by comparing the prevalence of stone disease in the wet zone and the dry zone. And we hope to set up surveillance sites to see how often are people getting stones. And the stones can be defined by a number of ways, including the number of procedures that patients might have. This is a very hard outcome. We know for sure that if you get a stone procedure, you had a stone. Also, diagnostic codes for stone disease admitted to the hospital. And then thirdly, maybe doing ultrasounds that can verify the presence of a stone. So those are sort of the three criteria we're hoping to get this idea of how prevalent stone disease is in these different regions. The second aim is to do a very complete, comprehensive analysis of risk for why patients get stones. And so we are hoping to recruit 20 patients with stone disease in the wet zone, 20 patients without stone disease from the wet zone to serve as a control, and then 20 patients with kidney stones from the dry zone as a comparison. And we hope to collect the stone for biochemical analysis, do 24-hour urine collections, and then to conduct a food frequency questionnaire to figure out what these patients are eating in their diet. So the idea is that right now we know that we have patients in Sri Lanka who have kidney stones, but we would like to know even further, what is their diet? Are they eating more like this or more like this? And what is the corresponding urine that leads to the minerals that form the stone? And so this would give us a more comprehensive picture of why these patients are forming stones. And then our third aim is to look at the water quality and to map water sources in the dry and wet zones of Sri Lanka. And a lot of this work has already been done by investigators in the CKDU project. Our focus is going to be more on the water mineral rather than necessarily on chemicals, just because the link between chemical exposure and stone disease is actually not that clear, and whereas the link with minerals in the water might be a better way of looking at it. So this is my last slide, second to last slide. So I just wanted to say here that, when we consider risk factors for stone disease in Sri Lanka, there are many factors that actually can contribute to stone risk. So we know climate, it's hot here and it's humid here, that can lead to more sweating, and insensible losses can reduce urine volume, that can increase urine supersaturation for growth of kidney stones. The diet can potentially have a lot of salt and protein and less fruits and vegetables. That can also contribute to stone risk. Water quality in terms of water hardness may also be a contributing factor. And then something I haven't had time to talk about is genetic risk. And this is something that Dr. Nanyakara has mentioned last month, that maybe we could also look at genetic risk in terms of why maybe some patients in the area is forming stones more than others. Okay, so this is my last slide. And again, I just wanted to thank all of you for taking the time in helping us with this project, and also this week for Dr. Nanyakara, Dr. Chandradrith, Dr. Harith, Dr. Hadiwadich, for taking the time to show us around, go through on hospital rounds, as well as looking at the sites in Wogamoa and Mandar Nora. I also wanted to specifically acknowledge Shaminda. I think he's been working really hard this past year on going to these sites, identifying patients, interviewing them for the demographics, doing the food frequency questionnaire. He's going to continue to do the 24-hour urine. This is him right here doing a great job of getting the dietary recall. I think without Shaminda's help of actually getting this samples done, we couldn't do this. So really thank you, Shaminda, for all your hard work. And then I also want to thank the CKDU team and Dr. Anand for really just involving me in the CKDU project, because this stone project is basically using the CKDU as a foundation for much of what we're doing. So with that, I'll stop and happy to take any questions.